Should we get going here? Erica, do you have anything, other introductory statements that you want to express to the group?
Yeah, I think we've got a pretty good participant list, so we can get started. Nothing from me today. Oh, actually, I lied. I already lied, Vince. Our Montana AMS program, we are switching it up. As you guys know, we usually would run during our budget period. And as Jenner and I have been working through data and talking, it makes more sense to do calendar years. So January 1st, 2023 is when we will start our new AMS program. So we will be sending out an enrollment letter as well as an enrollment survey and the deliverables for that upcoming year. I highly, highly, highly recommend facilities to participate in that. We do help you meet several of the 7 core elements of stewardship. I know Jenner's been expanding her work with our AMS program. We have lots of fun data we're going to be sharing with facilities. There was a presentation last Thursday on our efforts. So just want to give you guys a heads up. Please do keep an eye out for an email from me so we can get you enrolled. We'll probably have enrollment due around the middle of January just to give people some time to get enrolled and all that good stuff. So that's all I have. Back to you, Vince.
Oh, you're like a news reporter or something like that. Back to you, Vince. Well, welcome everyone. Thanks for signing in and joining us on Zoom. Hope everyone had a great Thanksgiving. Hope your holidays look all real festive as well. So, we're composing this, and some weeks we have presentations, and I think Dr. Simons last week gave a really, really good presentation. It was really intense. You can tell she's that group over there at St. Peter's and Helen has been doing a great job of antimicrobial stewardship and starting really from the ground up and working at it. So this week we're going to try to this month and into next month, we're going to approach it just a little bit different because we want a little bit more participation, engagement, and so on and so forth. Please don't be shy. Everybody has these questions, and just to use an old adage or cliche, right? The only question that's dumb is the ones that you're not asking. So everybody has the same issues, questions, and so on and so forth. So we'd like to share those, get those experiences and have everyone share those, or a case and so on and so forth, a question, a dilemma. So we're going to try to push that envelope a little bit further as we go forward here. So going back to, so number one, any burning questions out there from the group right now that anybody has right now? Any questions on anyone's mind that you'd like to ask? Jenner, Dr. Koo, Erica, myself, or someone else in the group? Hearing none. How about with the urinalysis and the asymptomatic bacteria and so on and so forth, that whole series? We spent a couple of months on that because that's kind of a rock in everyone's shoe, and everyone has an issue in dealing with that and managing it and so on and so forth. And it's always this ongoing issue and seemingly changing and so on and so forth. So anyone out there right now have either a case about that you'd like to discuss and say, what you did over the last couple of months helped me, didn't help. I was hoping to get this, but you didn't do that, or you did do this and it was great. You have a case and you have a question about it. Or the other thing I would ask is Heidi, Dr. Simon last week presented 6 different scenarios or steps, projects that they had embarked upon. Anybody do the same thing or similar things, or had reason to contact her in getting started with any of those? So any comments about any of that stuff, any feedback or case that you'd like to just kind of throw out to the rest of the group? Any projects that you're thinking about?
Or maybe, if you don't mind me interjecting here. I think just since after those two sessions we had, now what have you tried? What did you get out of that, and what have you tried? I'd love to have some feedback. And I mean, don't be afraid. No, we're not here to judge or anything. But if it works, it'd be great. But what we really want to our goal is just to get some of you to kind of give us some feedback about from based on what we've learned. This is what we tried. This is what we're going to implement, and kind of go from there. And if there's an idea that you want to try, but you're having some barriers, we're definitely let us know. We'll see what we can suggest to kind of help overcome those issues and such. So anyway, let's start with that. I think that just what have you tried anything regarding UAs, and is there anything that and how successful you are? I see a hands up right there.
Yeah, Holly, go ahead.
Yeah, I really enjoyed that presentation that she did. I'm pretty sure I've got the audit tool that she sent out. And so I adapted that to fit our facility, and we'll plan to start doing, set out a schedule. I think that's kind of on the back burner for January, to start doing routine kind of scheduled audits of the catheter, how it's handled, how it's cared for in both our long-term care and our cost. So I have not started it yet, but it's in the works to get started.
Great, thank you.
Yeah, excellent. Thank you. There's another hand up. Jennifer? Maybe not, no? Who else had their hand up?
Just curious, has anybody tried order set hygiene? And what I mean by that is just one of the things that I had suggested, just to go through, if your facility uses order sets, to just go through the commonly used order sets and purging them of your UAs and urine cultures, particularly in the ER or admission orders.
Holly, were you raising your hand?
Yeah, I was just going to answer that. I did pay attention like through this last couple of weeks during just my normal surveillance, and it's not an automated order in the automated order set for our ER patients. So it's just based on provider preference when that's ordered. So.
And I surmise that you probably haven't had enough time to see if there's a difference, but I know if you're taking some steps to kind of see if you could set it up so that you can compare and see how that effective. Now, granted, this is likely not going to make a huge change in impact your, let's say, for example, your antibiogram or whatnot. But I think that your goal is these are going to be small little steps which you can take to reach to that. The ultimate goal is to reduce significant number of treatment of asymptomatic bacteria by eliminating some of those automatic orders or from certain places like the ER or if you're there, from the surgeons, when they do pre-surgical and orders, because that's another very common place where that surgeons like to get these UA because that's how they've been taught. So anyway, any other ideas or anything else have you implemented and tried?
Or planning? Any ideas that you got out there that you're ready to embark upon?
Lacey,
go ahead.
Working hard on blood culture contaminations and false positives, and just trying to make sure that we get our ED staff to just get back to the basics of skin prep and things like that. We found a lot of issues around that. We still say around the 3%, but we're also kind of wondering, well, why are we okay with 3%? Like, can we do better than that? And I think we actually did a fact-finding session with our lab crew yesterday and talked through some of the barriers with things that they see. And one of the things they said was that a lot of times there's no real criteria being met to draw blood cultures, and the ED providers are just drawing them. And so it kind of brought up provider education, and sometimes that can be difficult as an infection preventionist to get that through to them, or like, what's the best way to bring education to the providers on when it is appropriate? I mean, I know they know that, but a lot of times they're just trying to cover so many bases, if that makes sense.
Absolutely. And actually, that's a topic that's a little close to I've been working on here at Billings Clinic, because we have had a significant increase in our blood culture contamination rate. I think we're like around close to 5%. So, but just for all of you that when Lacey had mentioned about the 3%, that's actually an arbitrary cutoff, a threshold that I think someone determined, and there's really no evidence based on that. I mean, the goal should be to get as close to zero as possible. So, I mean, so my goal is to try to do that, not try to just get to 3%, because there's really no evidence to really support that practice. But this is I think the first step comes out to approaching blood culture contamination rates and trying to reduce that is really to, which is what you mentioned about briefly, is looking at the basics, because certainly that, if you don't have that foundation laid out, how the proper blood collection techniques, when it should be collected and all that stuff, that's, anything else you put on top of it, it's not going to really be as effective. And and one of the common things I hear about is, should we bring in those blood diversion devices? I don't know if you know what those are. I think there's two companies that make them. One's called SteriPath and another one's called Curin. And the idea is that you attach a little device to the that connects to the syringe or to the butterfly needle that you have, and it will will divert some of the initial draw of the blood into a little reservoir. And the idea is that when you stick someone, do a venipuncture, there's a plug of skin that always gets sucked in, and that you can't even despite very thorough disinfection, you may not, or using antiseptic, doing antisepsis, you may not kill off all the bacteria. So the idea is to suck that little piece of the initial blood, volume of blood that may contain the plug of skin into another reservoir, and then you can draw the rest, which should, in theory, shouldn't be contaminated, and it should be sterile in the context of from the skin. So now there's pros and cons in that, because it costs money, and it also involves training your blood draw technicians, whether phlebotomists or your patient care techs or whatnot, into making sure that they're using the device correctly. So, but anyway, but I think that what you just mentioned, a lot of those is going back to the basics, at least from the phlebotomist of blood draw section. So make sure that the skins are appropriately prepped, that the disinfectants are allowed to remain on the skin for its appropriate duration of the kill time, things like that. But the other thing is education, and you're right, that is probably going to be the biggest hurdle, because the indication to draw blood cultures kind of varies amongst clinicians. There are certainly indications when you're going to that clinicians know, hey, this patient looks like has sepsis, we need to draw blood cultures. And that kind of evolves from all the SEP1 and the surviving sepsis campaign. But that's only a small proportion. The vast majority of blood cultures are really due because of fear or past experience from the clinicians, and that's hard, and that's a little harder to overcome. I think that in those cases is having a set an algorithm, and there's some studies that looked at this. If setting up algorithm, having a reference guide where clinicians can kind of look at to say, these are the conditions of where blood culture should be may consider to be drawn. And a lot of that is focused on, do you suspect the patient to have an infection? And you may have to really be more list some like criteria. What would you, in what condition would you a clinician to suspect infections? And I'm happy to kind of send, I have to dig up that article, but there was this article that looked at that actually, and they had some success. And that, having education and references are teaching those clinicians on when to draw blood cultures. So there are different approaches in that, those are kind of some of the approaches, and, how do you try to educate your clinicians when they should be drawing blood cultures. Ultimately, probably the hardest part about education is overcoming their fear of missing something. That is going to be the hardest part. And this is something that you just have to build that relationship with the clinicians, because ultimately they're going to keep referring back to, this is my license on the line, things like that. And it's really frustrating because they can apply that to anything. And that's the problem. Even if it has nothing to do with infections, they can always use that argument. And that's the hard part. And so it requires a little bit more of building a relationship. Now, there are other things like using clinical decision support tools, like if you're inclined to work with your IT folks to develop like a little algorithm in the ordering set. That's where they have to check off, just kind of like same thing like C. diff, where you do have a little checklist that say, had diarrhea, no stool softeners, no laxative, things like that. And that you could try to do that. And that, but that may get a little challenging because blood culture is a lot, it's hard to kind of peg blood cultures into a very specific narrow indication because it's used in so many different regions. And this is actually, this topic by itself can last like months. I just don't worry. And we're happy to kind of present if this is an issue, a very common issue, which is for other places. And certainly here in Billings Clinic, it is a big issue to kind of discuss about different strategies to address blood culture contamination rates.
Yeah, we actually did implement Curran here recently as part of our efforts. And what we kind of feel is that skin plug issue thing is great. However, it's kind of a Band-Aid if you don't have those basics down. So we're really trying to nail that into our nursing staff and our lab staff, because our ER staff was actually drawing into SBS yellow tubes, which is, so we've changed a lot of things to make it, better from the get-go. But yeah, that'd be a great topic.
And I think that certainly that falls into, it has antibiotic stewardship implication, but this is primarily actually a diagnostic stewardship issue. But Lori.
Hi, yeah, I just was going to toss in there too. I actually live in Alaska, so I'm not in Montana, but Montana is also rural. And as you're looking at that, I know a facility I worked at in the past, we were looking at our blood culture contamination rates. And of course, they were particularly high in the ED, of course, first point of entry. And I'm sure that's where many blood cultures probably in Montana are taken as well. When we really dug into it, what was happening was we had a medevac system where, of course, we're very remote and almost everyone would get flown in on a medevac, not a traditional ambulance. So let's clarify that. But that meant that people were going out to remote villages, picking up, our paramedics were picking up these, patients and bringing them in, and they were kind enough to draw blood cultures. And I say kind enough, which was great, but they weren't always using the great techniques that you're describing. In other words, they probably weren't prepping the skin well. But to check those blood cultures they were going in under the nurse and the provider, of course, in the ED. So it really took some digging to do that. So I just wanted to toss it out there, because as people are trying to dig into some of that, there may be some unknown factor such as that may actually influence it. So we actually had to go back with the company and offer some training to the staff and, work with them on that. So I just wanted to toss that out there. Thanks.
No, thank you for that input. Because and again, this emphasizes that if your facility is experiencing a rise in blood culture contamination rate, the first step should always be review what your what your staff is doing, because usually you'll find something that they're falling out of standards that they should be following, whether collecting blood, disinfections, or how they collecting blood and such. I'm just going to give you an example for ours, and this is something that we never that infection control never endorsed, but then the ER started practicing this because it's easier, is to collect blood samples through their IV shortly after placing the peripheral IV. That is actually not a stand, and again, that's something that, when we're talking about drawing blood for blood cultures, we always kind of think about, making that specific venipuncture after appropriate disinfection, but typically not through a peripheral IV. And that's something we're working hard to try to change. But this is the reason they do it is because they view this as a time-saving measure, and so now we're having to go back and to work with our educators to unlearn that technique, because that's just so ingrained into them now. For the past 2 years since COVID-19 has started, we weren't able to review that, and they just start doing this. So no, I mean, and so it's really, as you're seeing, if you're running into issues, review what is actually going on instead of trying to apply new strategies, because a lot of times it's just the basic things that people are just falling out. And I agree with you, Melanie, because our phlebotomists are great, but they and have very low blood contamination rate. But our ER won't allow phlebotomists to go in there draw blood. So there is that. Yeah, it's a really weird setup. So anyway, that's my so again, yeah, look at the basics, look at what they're doing, because a lot of times, 9 times out of 10, that is where it goes. The time when you decide to do all these extra measures, such as using a blood diversion devices and such, is when you already maximize all those things, and then and you're not getting to where you need. Then that may help. Spending that extra money on using those devices may help with diversion. Although there are other ways, cheaper ways to do it, and this is something we can talk about in the coming months about those various techniques.
I would just add from my experience a couple of things. If especially from the educational aspect of it, do your homework first. What's and so some of you guys have actually done a nice job of describing this, but what's the problem that you're really trying to approach and define and get that information? Because if you uncover something that you didn't know, once you're trying to do something, it's like, oh, well, I didn't know that. And then now you got to put you back. You have to start over. The other thing that I've learned is when it becomes a large issue and maybe sensitive, whether you're dinging egos or there's a hierarchy there that you have to go find a champion and try to hook up with that champion and get some help, and rather than trying to do it all by yourself and educate all these clinicians, by yourself, find a champion that can help you kind of open that door and make some progress there. Okay, great. Thanks you guys for that feedback. That's excellent. And, we'll come back. This is, the generation of things that pop up gives us ideas going forward for sure. And certainly with the UA presentations and issues, those aren't going to go away. And we'll probably come back to that. We'd like to, bring that back in a way that what projects have you done in a few months, and then, re-explore that whole thing and who's doing great ideas, and we can capture those, and who's having issues, and what issues did you what barriers did you stumble upon that we can get through together as a group. So I think in numbers here, we can be very much more successful than independently approaching some of these things. So great. Excellent. Anything else? Don't see anything. Okay, good. Jenner, you want to throw up your question for our homework, and I'm going to have
Absolutely.
Dr. Koo kind of jump in and
Well, why don't I give the vignette and then that will lead to the question, because that's
you want to go
really
that
what-
way? Okay. Okay,
Yeah.
I was going to do the question first and then come back to it, but that's okay. Sure.
Oh, can I have control? May I have control?
You now have control.
Thank you.
Oh,
Appreciate
hey, if you
that.
got control from Jenner, that's good. That's
All right.
You have power.
she wielded it.
All right. Oh gosh, hope this works. Oh, darn it, hold on. Wrong one. Let me try. Good God, I hate Windows. Okay, all right. So we would like to I would like to kind of present a quick vignette, and this is just a made up vignette, but something that most of us have encountered, and just wanted to kind of set the mood per se to lead to the question and the homework question that Jenner will kind of present, and hopefully we'll kind of break down and do similar breakout group next time we meet to kind of talk about what your experience at your facility when you encounter this scenario, and how and what ways we can kind of address the concerns or the issues. So so let me start with, let's see if we can do this. So really quick, so a 50-year-old woman, obese woman with history of diabetes, asthma, and hypertension presented to the emergency department with several days history of fever, malaise, headaches, and worsening of non-productive cough. The last 3 weeks, her 3 kids, which are ages from 9 to 6 years old, had similar symptoms. And her youngest child, who was recently diagnosed with the flu. She has not received, this patient has not received the pneumococcal vaccine, nor had this year's influenza vaccine. In the ER, presents with she appeared to have mild distress as well as but also dyspneic. She is febrile, low tachycardic, as well as tachypneic, and her blood pressure is 150/99. Her oxygen saturation is at 90% of room air. Her physical exam is notable for scattered inspiratory and expiratory wheezes with a prolonged expiratory phase. Fine crackles were heard in the left lower lung field. Her laboratory data was really notable for leukocytosis with mild lymphocyte neutrophilic predominance. Her BUN is elevated is at 22 and creatinine at 1.7 and glucose at 280. And the ED doc performed a nasopharyngeal swab, sent it off for a multiplex PCR, which detects flu A. The chest radiograph shows as follows. And for those of you who know, there is there is a increased opacity over the left lower lobe. The ED physicians then proceed to order some blood cultures because of concerns of possible sepsis based on the fever and tachycardia, as well as a leukocytosis, and started also tamivir, ceftriaxone, and azithromycin. And and the request for admission was placed by the admitting hospitalist. The hospitalist, because there were a lot of patients needing to be admitted, didn't just continue all the antibiotics, antimicrobial agents that the ED doc has prescribed. And then the attending hospitalist, which is the doc who picks up the patient the following days, just decided to continue with those antimicrobial orders. So just want to kind of start this discussion with that vignette to kind of I'm sure a lot of you probably will, if you admit patients with flu, which is what we're seeing quite often, pretty prevalent now. It's widespread in Montana. These patients were coming in with acutely ill respiratory distress due to influenza, and now gets put on this barrage of antimicrobial agents. and how, and I think what leads to Jenner's question, how often do you see this? How do you address this?
So question for next week, and we're happy to take feedback on what you've seen right now, but it would be fantastic if you could all go back to your facilities and kind of, take a little survey, try and get an idea of how many patients are coming in and they're being, diagnosed with confirmed viral respiratory illnesses, but then also being placed on antibiotics. And then in addition to that, what other tests are being run on these patients that maybe are not necessarily appropriate based on that diagnostic? So are you seeing a CT chest angiogram on every patient that has a positive influenza test? Are there, it's full sepsis protocol being run on every patient that has a positive influenza diagnosis? What other kinds of tests are you seeing that maybe are not necessarily what we would have seen for treatment of influenza, 4 or 5 years ago before we had, an outbreak of COVID and didn't see influenza for a while? Any thoughts right now? What are you guys seeing in your individual facilities?
Are you admitting mini flu cases?
Yeah. Are you
Or
seeing
some.
influenza?
I feel like anytime that our providers see an underlying possible pneumonia, they are treating with antibiotics, regardless of a positive viral panel.
Colleen says lots of influenza.
Robert?
No, and Erica just chatted in the weekly influenza summary. Robert, did you have a comment?
You're a mute.
Feel free to chat as well. Oh, influenza and first RSV employee.
Robert, you may need to press, I think, *6 to unmute. It looks like you're on the phone. I don't know if that helps.
There we go. Thanks for that. It's kind of a disconnect with our system's policies using Zoom. And anyway, just figuring out with the call-in feature. I was just going to reiterate pretty much everybody else seeing lots of flu. Pretty much anybody is initially started on antibiotics, and then various levels of comfort with the individual providers, whether they're willing to discontinue or just give them a full course.
So that brings up a question. That's thanks, Robert. That brings up a question that I had. And if you're seeing that broad spectrum coverage, antimicrobial wise and antibiotics and antiviral, are there orders in place anywhere? Does anybody have orders in place to revisit the antibiotics and then put in any sort of a request to discontinue the antibiotics at some point in time, 24, 48 hours or anything like that? Anybody have that on board? Nothing. Seems like we're getting a lot of comments around the board about not as many influenza in our community. Antibiotics ordered, patient risk for other problems. Influenza currently dominant influenza. Is this so that this question, this scenario, is that relevant? Do you guys think that we should kind of go down this road and discuss this a little bit further in detail and see what we can produce from this? That sound good? Okay, good. Looks like it.
Well, Liz says this is one of the questions we ask on our ICARs too, so that's great.
Okay.
And this is a very interesting, I enjoyed the responses from all. We at Billings Clinic, we actually have have been having very similar number of COVID-19 patients admitted as flu patients. So it's we actually have a lot of flu here. We and as well as Gallatin County. It does, and many clinicians, if they see that chest X-ray that I just showed, they are very much inclined to start antibiotics. And it would be interesting to kind of get some perspective of what's driving that, because you know, again, I mentioned about past experience and fear. I mean, there is that sepsis component, potential sepsis component, because this meets the SIRS criteria. But what can't, you know, and I'm hoping to lead into a little bit more discussion as well as strategies and trying to address your individual facilities, how to kind of alleviate some of those concerns, and what can we do to kind of to reduce antibiotic use, especially in these cases where it's clearly it's flu. So.
Excellent. So if you would all take that question back to your facilities, take it back to the providers that are writing these prescriptions. If you could get a little bit of information, obviously we would love if they can jump on and provide feedback as well. But if they can't, if you can get some feedback from them on, you know, what are the concerns? What is it that is driving that desire to, you know, prescribe antibiotics when we have confirmed influenza? What is it that is causing them to make those decisions? Or
And in addition to that, what can you do? What can be done to alleviate those concerns? Right. And that's I think that's maybe something really that probably more important, because that's what the lack of something to give that confirmation is probably why they continue to continue with giving antibiotics.
So in January, one of the things we were talking about doing when we reconvene would be to break off into those groups again, and then discuss them in groups, come back together as a full group then, and then share what the individual breakout sessions, breakout groups came up with, and then go from there. Sound good?
any other questions? We'd like to take advantage of having Dr. Koo on here.
And actually, this is the first time we have actually extra time, so definitely.
Yeah, we're usually scrambling for time, so.
It does look like people are interested in doing some presentation or education on blood cultures moving forward. So I think we can definitely add that to our education for 2023.
Excellent.
Any last thoughts or comments? If not, we'll send you all back to work a little bit early.
Or any other topics as well for this coming year, since we're talking about it now.
Yeah.
So we got two, right? These viral pneumonias and antibiotics. We got blood culture contamination rates. Any other issues that you've encountered at your sites? And let me kind of want to caveat this is because I don't want us who work at larger facilities to dictate what the topics, because we don't know what goes on in your sites, and you may have a completely different issue than what we're experiencing. So I mean, we want these sessions to be more helpful for you, not what we think that will help, what we think you should know about.
As always, if you think of something once we get offline, don't hesitate, contact any of us, and we'll gladly engage in that discussion with you, or put your idea down for future discussion within the group.
So we did get a question in chat that I think is similar to some other questions I've been getting lately, is being a new infection preventionist, how do I get a provider to reconsider the use of antibiotics? And I think this is definitely something Jenna and I have been receiving questions related to. So I think any insight that you guys can share on that.
And it can be from anybody in the group too. What works for you as an infection preventionist when you're working with your providers? Nothing, Dr. Koo?
Well, I would,
Oh, go ahead, Vince.
well, so I'm just going to go based on my experience. If it's an individual provider, I think approaching that provider initially to kind of initiate a conversation and dialogue about antibiotics and their prescribing habits and so on and so forth. Rather than coming right at them and saying, well, you're doing this wrong and you should be doing this, and here's the data for this, and here's the suggestions and the guidelines and so on and so forth. That, I mean, in my experience, that just kind of puts that provider on the defensive right from the get-go. And so initiating that conversation with them right away, if they're open to it, it's like, yeah, I'd love to have somebody else do this. Let's go down this road. Let's optimize this. And so on and so forth. If they're very resistant to that, if they're in some of the smaller hospitals, I know it's you have one provider or two providers or several providers, whatever. Again, finding that champion with you and engaging with that individual and getting some other ideas, because if you're running into that resistance from that initial conversation with them, you're going to have a little bit more difficult time in approaching, how to from just saying the same thing in a different way. And I think you're going to have to get other help. That's been my experience before you kind of get the whipping stick from administration or some sort of an accreditation tool or something, like that. I think it's easier to kind of catch the flies with honey as it is with vinegar in that situation. So I try to find that if I can't in dialogue with that individual and work with that individual initially, I go for help with another provider or physician in terms of approaching that individual and seeing if that works. Sometimes that doesn't work either, but it's step A and step B before you have to go to step C.
And I agree. And again, I'm going back to this. It's all about relationships, building that relationship. If again, this is like anywhere else, right? If you don't have that really good relationship, have established that relationship, it's hard to try to convince someone to do something they're outside of their comfort zone. Remember, antibiotic use is really one of those issues where there a good number of the times it's the CYA strategy when they don't know what's going on with their patients. So a lot of the nudging that we strategy that we're trying to use, things that we do to nudge clinicians really is figuring out, how do you kind of use your relationship with that clinician and how do you convince them and understand what are the issues that's going through their mind. Again, I kind of listed a lot of it is fear, a lot of it maybe they've seen something bad happen in the past, and you kind of have to address that. Or there's just that they need the expert advice, and that's actually why the pharmacists are very important in any antibiotic stewardship program, because they offer the expert advice in the use of antibiotics. And then and I know many of your facilities don't have a direct access to an infectious disease physician. We can kind of have someone who can arbitrate a case, right? To say, no, this is how you do things and such. So a lot of times they're really responding to in the way that they understand. And at the same time, they just don't want, their fear of missing something. And so that, so we want to, so that's, understanding where they're coming from, and it's different for different clinicians. That is going to be essential in coming up with a strategy of how to nudge them. And what we're trying to do here is different ways of nudging depending on the various situations. So I know it's kind of a little easier said than, and so it's really is all about relationship and how you build that, and how do you make yourself readily available to help them into that. And then finally, certainly, you want to make sure that they understand that you're doing this to work with them, not to penalize them. And I think many times if you approach them in the question why you're doing this, they're going to perceive that as like you're being big brother telling them what to do, which is really not what really going to be counterproductive. So you want to kind of work in the context of working as part of their clinical team. I think that's and I'm going to respond to Katie because he was a quick question about osteomyelitis. That's actually a little bit outside of the context of antibiotic stewardship, but I am more than happy to kind of talk to you offside or one of our ID docs offline about that, because that's really a clinical management of a disease.
Thanks, Neil. That was there's another comment on there about we hear when patients come in and put their money out, they expect to get something. I've heard that as well too. And last year, I gave a presentation. One of the projects I did years ago was kind of around that same thing, because that's what we heard. People come into the ER, right? They don't get something and they think they have a bacterial infection. By God, they want an antibiotic, and if they don't get it, they're gonna be pissed off and da. And so we took that approach very shortly and succinctly. And if it was diagnosed that they did not have a bacterial type of an infection, rather it was viral, we had them fill out a card. And what they got when they filled out that card, here's the reason why you're not getting the antibiotic that you're seeking. Rather, you're getting a nice antiviral kit, which had Kleenex and antihistamine and decongestant if it was appropriate, and so on and so forth, and education and so on and so forth, why they didn't get that. And it was about an 85% acceptance rate because they didn't get the antibiotic, but they got this other stuff. Here's why you didn't get the antibiotic. You have a viral cold, antibiotics aren't going to work, but here's some stuff to kind of, placate those symptoms and manage the symptoms of that virus until it goes, viral cold until it goes away. And that seemed to satisfy. But so you got to kind of think outside the box on that, because the patients are going to drive a lot of that stuff, right? And that's a great question, and that's a great comment. Well, the patients want this. What are we going to do about it? Well, how do we appease the patient? So there's that patient education and component of it as well too. So yeah, great question. Okay, anything else before we, I guess, sign off for the month? Jenner, Dr. Koo, Erica? Anybody else?
I think my only comment is that our next session will be on Wednesday, January 4th, same time, 11 a.m. to noon. So we hope that you can join us, and we did give you homework this time, so we will be reviewing that homework question. That's it from me, Vince.
Thanks, Erica. Jenner?
Nope, I'm good. Thanks, everyone.
Dr. Koo?
Thank you.
Great. Thanks, you guys. Hope you have a joyous holiday season.
Merry Christmas.
Thanks,
Happy
Vince.
holidays.
Dr. Koo.
Merry Christmas.
Bye, y'all.